chairpersons. Next, we'll move to our second session. To chair the second session, we have with us Dr. Anjan Datta, Dr. M.V. Bhimeshwar, Dr. E.K. Ramdas, Dr. Joy, Dr. Lenin. Welcome to all the chairpersons. Our first talk is in this second session.
Shilpa, 1 minute. We are 1 minute behind. Should be. I think we can start exact time because we are before time. 1 minute. So if people are coming 10 o'clock, we can start at 10 o'clock. At that time, we can start.
Okay.
Because we are 1 minute before that. So if some people are coming from other hall to this hall, we will wait for 2 minutes. Meanwhile, I can introduce the three chairpersons and see we have the chairpersons, Dr. Joy Prakash Jana, who is a consultant anesthesiologist in Pune, who is an ex-GC member. He is the person who gave the anesthesia for the uterus transplant in Pune. And other is Dr. Lenin Babu, who is professor of anesthesiology at Jipmer, Pondicherry, and who was the secretary of ISA Pondicherry branch. And next is Dr. Anjan Datta. Anjan Datta, he told that he has another schedule and he is a past national president. He will be joining that. He is a past national president of ISA. Then Bhimeshwar is the past national secretary, ex-major, and he was with the IPKF in Sri Lanka during that period. He was the past secretary of ISA, and he was the two-term GC member and registrar of evaluation of Health University, Andhra Pradesh, NTR Health University. Now he is a professor of anesthesia at Kadapa. Colonel Bhimeshwar, he has just transferred to okay. And who is the other chairperson? I'm not in this, that's why I'm not able to view them.
I think Dr. Kotur is the chairperson.
Okay, Kotur.
Dr. E.K. Ramdas and Dr.
Okay, Dr. E.K. Ramdas, he is at Baby Memorial Hospital in Calicut, and he is the past president of ISA Kerala and a renowned faculty in all our conferences. With this, I introduce the speakers, and Shilpa, now you can start with the talk, and they will take you to the next level. Thank you all for this. Thank you.
Okay, sir. Yes, next we'll move to our first session, that is talk by Dr. Shalopal, and over to Doctor.
(33 weeks) presents with history of headache and visual disturbances, worsening pedal edema, and decreased urine output. BP recorded is 170, 110 millimeters of mercury. Labs show a normal PCV, platelet count of 90,000. There is a deranged liver function with renal failure and proteinuria. What is your diagnosis? Severe preeclampsia with a BP of 170, 110. HELP syndrome with platelets of less than 90,000. Impending eclampsia suggested by premonitory symptoms. Now, the solution to the problem is termination of pregnancy. So the patient is posted for emergency cesarean at 33 weeks of gestation. How do you proceed? Preoperatively, the patient should be assessed early and reassessed because the scene changes very rapidly. BP should be controlled, seizure prophylaxis should be done, and fluid status should be maintained. Coagulation status decides on the choice of anesthetic. Even one dose of steroid may help neonatal lung maturity. Our patient has a BP of 170-110. The target BP is 170-110 or less, and the systolic BP should not go below 140 millimeters of mercury because uteroplacental circulation will suffer. The first line of drugs are labetalol and hydralazine in injection form, followed by oral nifedipine. If this does not work, MTG and nicardipine infusion. And ideal BP should be 140 by 1 to 160 by 90 to 110. The only setting where diuretic is used pre-delivery is in case of pulmonary edema, in case of raised ICP. Sublingual because it can compromise on the already contracted blood volume. Sublingual nifedipine is contraindicated because it can cause precipitous falling BP. Is seizure prophylaxis intended in these patients? Answer is yes, because patient has got severe disease and also there are symptoms of impending eclampsia. The drug of choice is magnesium sulfate for prophylaxis as well as treatment. After initial IV bolus, blood level is maintained by IV or IM and it is continued 24 hours postpartum or the last seizure, whichever occurs later. What does magnesium therapy mean to us? It potentiates the action of muscle relaxants. There is poor response to sympathetic stimulation and atonic PPH may result. Fluid status in these patients is contracted. The anemia may be masked because of the contracted blood volume, and this means hemorrhage may be poorly tolerated. Recommended fluid is balanced salt solution of 1 to 1.5 ml per kg per hour. And if hemorrhage occurs, it's crystalloids plus blood transfusion. Colloids have no real role. Remember, pulmonary edema kills, but oliguria and renal tubular acidosis does not. These patients are prone to pulmonary edema, and this typically occurs 70% of the time postpartum, and it is because of iatrogenic fluid overload, poor oncotic pressure, and leaky capillaries. So it is better to err on the lower side for fluids. The first thing to get affected usually is the platelets, and subsequently PTINR and all can get affected if liver failure is there, and DIC can occur in case of uteroplacental separation. If the absolute count is 75,000 or above, central neuraxial block can be instituted. If it is below 50,000, it is absolute contraindication for central neuraxial block. Between 50,000 and 75,000, it depends on the trend in the platelet count, the effect of associated coagulation factors, and if there is DIC. Low dose aspirin is not a contraindication to central neuraxial blockade. In low molecular weight heparin, if it is OD dose for 12 hours. If it is BD dose for 24 hours, you should abstain from central neuraxial blockade. Catheter epidural is removed and this in the same situation as when it was put in. After 2 hours to 6 hours of removal, you can start on low molecular weight heparin for thromboprophylaxis. What are the anesthetic concerns in this patient? They are at high risk for acid aspiration, so aspiration prophylaxis should be undertaken. Should anticipate difficult airway in this patient because of edema of neck, tongue and larynx. And so all equipment and personnel should be ready for managing a difficult airway. Hypertensive and hypotensive responses are possible, and the contracted blood volume is a threat, and coagulation abnormalities may be present with neonatal depression, and PPH can occur. What monitoring will you use in this patient? Besides the common mandatory monitoring, if GA is given, ETCO2 and PNS monitoring is needed because the muscle relaxants have to be titrated. Arterial BP is easy to access and may come very handy in a case of refractory hypertension, in the case of labile hypertension, and in cases where vasoactive drugs are on flow. CVP and pulmonary artery catheter is rarely placed because it is difficult to place, and the correlation between CVP and PCWP is very poor. The one monitoring which is helpful is TTE, transthoracic echocardiography. This will help you know the status of the heart and the vascular volume, but the anesthetist should be proficient in it. What is your anesthesia choice for LSES? The preferred anesthetic is neuraxial block. Advantage is it avoids the hypertensive response associated with GA, and the airway could be quite challenging in these edematous patients. The spinal is the anesthetic of choice because it is less traumatic, can be rapidly achieved, and it is useful in a setting of urgency with fetal distress. We were brought up on the notion that spinal should be avoided in these patients because it can cause precipitous fall in BP, but things have changed. It has been documented that it does not happen. In a multi-centric study reported in Anesthesia and Analgesia compares spinal and epidural for cesarean in preeclamptics, and it was found that though the incidence of hypotension was more with spinal, it was transient and lasted for less than 1 minute, and it was easily corrected by a small dose of ephedrine. There was another study by Antonio et al. Comparing spinal for cesarean in eclamptics and preeclamptics and normal pregnant patients, and it was found that hypotension was more in the normal patient compared to preeclamptic patients. Central neuraxial block, we decided, is the anesthetic of choice, and out of this spinal the best. This is central neuraxial block is advantageous in patients who are normal, who have normal ICP, but convulsions, the seizures are controlled, and there are no contraindication for central neuraxial block. If labor analgesia, if epidural catheter in C2 for labor analgesia, it can be topped up to convert it into surgical anesthesia. Judicious co-loading is what is recommended to a maximum of 500 ml of balanced salt solution. If hypotension occurs, you do not treat with excess fluids, but treat with vasoactive drugs. These patients show an exaggerated response to vasoactive drugs. So, in small incremental doses are titrated to target levels. The uterotonic of choice is oxytocin, but if oxytocin does not work, prostaglandins is the next choice, but methyl ergometrin is avoided at any cost. General anesthesia is the anesthetic of choice for patients who are obtended, has raised ICP, convulsions are not controlled, and there is an urgent fetal distress, and there is contraindication for central neuraxial block. Rapid sequence induction is what is planned, keeping difficult airway in mind. The problem with general anesthesia is hypertensive responses which can occur at laryngoscopy intubation and at extubation. This can be detrimental to the patient because it can cause intracranial hemorrhage, myocardial ischemia, and pulmonary edema. We have a whole array of drugs which will help us in this. And remember to stick on to what you're used to. Labetalol 10 milligram boluses may be a good choice. Conventionally, opioids are not given before delivery of the baby, but in a case where it is needed, benefit risk ratio is more, then opioids may be used, but the neonatologist should be informed about what all drugs were used for the patient. Initially, the same dose of relaxants are used, but subsequent doses are titrated with PNS. Etracurium and cis-etracurium are the drugs of choice because of liver and kidney involvement. The subsequent doses are monitored with peripheral nerve stimulator. Awake extubation is what is planned after adequate reversal. Remember to attenuate stress response. Caution, hypertension, pulmonary edema, aspiration. Post-operative management is very crucial in these patients because they can have a lot of post-op complications. They are shifted to HDU for 24 to 48 hours. Analgesia is managed by multimodal approach. The NSAIDs are controversial because it can affect platelets, renal and hepatic function. Strict intake-output chart is maintained. Fluid is given at the rate of 75 ml per hour till such time the patient starts mobilizing her extracellular volume. Magnesium infusion continues. BP is controlled by analgesics as well as drugs. Pulmonary edema should be watched for, and seizure and obstructed airway could be a problem. Thromboprophylaxis is crucial in these patients. They are started on low molecular weight heparin and other measures for thromboprophylaxis. Efficient teamwork involving the obstetrician, anesthesiologist, and neonatologist is the mandate for a successful outcome. These are my references. Thank you.
Thank you, ma'am. Next, we have a session from Dr. Naresh Paliwal. Over to Dr. Naresh Paliwal.
Good morning, everyone. I'm very much thankful to ISA Kerala for inviting me to deliver this talk. My original topic for presentation used to be segmental spinal. Is it possible? But since many people have started doing it and given me the feedback of its magical reality, I have changed the title to Segmental Spinal, a Magical Reality. A little bit about the history. In 2006, the new era began when A. Van Zundert gave a segmental spinal at T10 for laparoscopic cholecystectomy in a patient with severe COPD. Since then, there have been many studies exploring its utility in many different surgical procedures like thoracic, abdominal, and breast surgeries. The term is often used synonymously with thoracic spinal anesthesia, but in real sense, blocking of the required dermatomes is essential for the proposed surgical procedure with very low effective local anesthetic drug. This often necessitates dural puncture at high lumbar or mid to low thoracic levels. Lower the dose, more likely to produce a true segmental block. Yes, practically all the abdominal surgeries, superficial thoracic and breast surgeries are possible under segmental spinal alone or combined with epidural. If that's not all, then the option of continuous segmental spinal anesthesia with spinocats is also possible. Some anatomical aspects are crucial for segmental spinal. There is natural thoracic kyphosis at T765. Amount of CSF at thoracic levels is very less. Thoracic nerve roots are very slight and thin, favoring its efficient blockade. There is no difference in the onset time for isobaric and hyperbaric drugs at thoracic levels. This is a picture depicting how to identify the thoracic intervertebral spaces for giving thoracic spinal. The C7 spinous process is a prominent one. Then the spine of the scapula corresponds with T3. The inferior angle of the scapula corresponds with T7. This is lateral MRI showing the angulations at the mid-thoracic levels, angulation of the spinal processes, then the ligamentum flavum thickness, epidural space width, epidural pressure, dura, spinal cord, etc. This is the main slide, midline MRI of the spinal column. In this you can see the cervical enlargement fills almost the entire spinal canal at the level. In the thoracic segments, the spinal cord is positioned much anteriorly, leaving a significant space between the posterior dura and the spinal cord. At the lumbar level, the lateral space disappears almost completely. This is a magnified view of the same MRI. You can see here there is a sufficient space to introduce a spinal lead at mid-thoracic levels. There are some major issues raised with thoracic spinals. The first is a neurological injury with dural puncture at thoracic and high lumbar levels. The second one is ventilatory impairment due to extensive thoracic nerve blocks. And the third one with high spinal leading to bradycardia and hypotension. Coming to the first issue, neurological injuries. As you have seen in the previous slides, the space between posterior dura and the spinal cord was measured, and the spinal cord lies more anteriorly in thoracic region, while the cord and cauda inguina touches the posterior dura at the lumbar levels. The distance is widest at the mid-thoracic level in all positions, more so in the lateral and sitting positions. These are the positions we usually acquire for giving spinal anesthesia. This is a possible explanation for very low rate of neurological injuries after accidental dural puncture during thoracic epidurals or intentional dural puncture in segmental spinal. With thoracic epidurals, it may be seen as a hazard as we are not ready for it, but with thoracic spinal, it is even at a low risk as we are ready for it and with a fine needle. In one study, it was found that many anesthetists frequently use very high lumbar or thoracic spaces, especially in morbid obese and parturients. In that study, only 29% were found to be correctly identifying the intervertebral space for spinal anesthesia. The Imbeloni and Govia, they measured the exact distance at T2, T5, and T10 level. You can see it is maximum at T5, 7.75 millimeters. Lee and his colleagues, they studied the anatomy of the spinal cord in relation to the surrounding structures, and they found that in supine, lateral, and sitting positions, the distance is more than at the lower levels. This is a diagrammatic representation at the thoracic, lumbar, and caudal levels. This is again at thoracic, thoracolumbar, and cauda-inguinal levels. This is again a lateral view of the MRI. Because of the angulation, the mid-thoracic levels, the angulation required to perform a spinal that further increases the distance between the posterior dura and the spinal cord. It will be more clear in the next slide. You can see here the distance is almost 8 millimeter. Feeling is maintained that sustains the outflow from the intrinsic chronotropic receptors in the right atrium and great veins. The less hypotension is usually due to the less vasodilation and less peripheral pooling because of the low dose of drugs used. Indications: till date it was used mainly in patients with multiple comorbidities for gallbladder surgeries, but can be a useful technique for all intra-abdominal surgeries, thoracic and breast surgeries. Reports of its successful use have been quoted for awake thoracoscopic surgeries like bullectomy, thymectomy, lung volume reduction, and vase resection surgeries, and also for breast surgeries. In breast surgeries, the recurrence rate has been found to be diminished as compared to when done in general anesthesia. It can have certain advantages or routine spinal anesthesia, like surgeries thought to be out of domain of spinal anesthesia are possible with segmental spinal, like upper abdominal, thoracic, and breast surgeries. The higher levels of the block can be achieved with just half the dose that is required at lumbar levels. And there can be very minimal hemodynamic fluctuations, early recovery, and voiding. It can have special advantages over general anesthesia in patients with respiratory comorbidities, can avoid post-op pulmonary complications and ventilatory support. There is also a lower incidence of post-operative nausea and vomiting. Both isobaric and hyperbaric drugs can be used in segmental spinal. Even a combination of hyperbaric and isobaric drugs can be used in some abdominopelvic surgeries. In general, isobaric drugs are preferred for laparoscopic, thoracic, breast, and open intra-abdominal surgeries where relaxation is not an issue. Hyperbaric drugs can be a choice for open intra-abdominal surgeries, especially in male muscular patients. There are certain advantages of using isobaric drugs, usually preferred as they are less sensitive to position issues. When used in low doses, they have a propensity to block sensory nerves in preference to motor ones. Sometimes it is labeled as a selective anesthesia. Other advantages of isobaric drugs are onset is gradual, there is hemodynamic stability, even with high levels of block. Motor block time is shorter, leading to early ambulation and voiding. In lateral and prone position surgeries, spinal can be given after placing the patient in operative position directly. In combined spinal epidurals, spinal can be given before epidural and at a space higher than epidural without worrying for unilateral effects. Addition of small doses of fentanyl, dexmedetomidine, or clonidine can cause increased intensity of sensory blocks. Among the isobaric disadvantages of isobaric drugs, the levels of block cannot be modified by any change of positions. Drugs need to be placed at the precise dermatomes. Like in epidurals, sacrum sparing is common when low doses at higher spaces are used. It takes some time for onset at lumbar levels. A slightly less muscle relaxation, so you may need some higher doses in male muscular patients, and there is always a time limit as with any low dose subarachnoid block. Amongst the available drugs, isobaric drugs like chlorprocaine 1%, deobupivacaine 0.5%, ropivacaine 0.75%, hyperbaric drug bupivacaine 0.5%, they all can be used for segmental spinal. The chlorprocaine 1% is isobaric, being 1% the volume required is more. It's useful for short procedures of 40 to 50 minutes duration, and with volumes of 3 to 5 ml and spinal at even lumbar levels is enough for laparoscopic surgeries of short duration, and patients can be mobilized within 2 to 3 hours. Ropivacaine 0.5% and ropivacaine 0.75% are comparable. Ropivacaine is less lipid soluble and is half as potent as levobupivacaine intrathecally. There is a stronger differentiation between sensory and motor blocks with ropivacaine. Levobupivacaine 0.5% is usually a preferred drug for laparoscopic upper abdominal thoracic superficial surgeries and in morbid ill patients for mid-duration surgeries. Bupivacaine heavy 0.5% can well be used in same doses as aspheric drugs in segmental spinal with just half the dose that is used at lumbar levels. Onset time is usually reduced to reach the T3 levels. Duration of motor and sensory blocks plus hypotensive events are significantly lower with low dose as compared to doses used at lumbar levels. The gravity-dependent spread has to be kept in mind when using steep tilts for laparoscopic surgeries, and for open surgeries can be a better choice in some healthy male patients. How to decide which space, what dose for a particular surgery? It depends on the type, site of surgery, average duration, comorbidity of the patient, and whether combined with epidural or not. Dose of local anesthetic and site of injection along the nerve axis can be varied. In general, 1 ml of the isoveric drug spreads 2 to 3 segments above and below the site of injection. And what that means is 2 to 2.5 ml of the drug is sufficient to block segments from T2 to L5S1 if spinal is given at T10 level. 10 thoracic space lying in the center of the surgical field for upper abdominal surgeries. For all intra-abdominal surgeries with adequate dose, thoracic spinal above T10 is hardly required. A space between T10 and L1 and a dose of 2 to 2.5 ml with some additive is sufficient for 90 to 120 minutes duration. The regression of effects from lumbosacral roots starts varying after 70 to 80 minutes, and for surgeries involving pelvic manipulations like TLH, you can use a combination of hyperbaric and isoveric drugs for prolongation of effects at lumbosacral roots. For long duration procedures or in patients with multiple comorbidities where you want to use a very little dose intrathecally, epidural can be placed at the same level or one space above. Epidural has some advantages when used with segmental spinals. It can be used to cover the inadequate levels. Also by epidural volume extension technique, it can spread the low doses used intrathecally and also useful for post-op analgesia. For breast and superficial thoracic surgeries, spinal needs to be given at mid-thoracic levels with just 1 to 1.5 ml maximum of isoveric levobupivacaine with some additive like fentanyl. This will provide a duration of 60 to 70 minutes maximum. For prolonged procedures, it is better to combine it with epidural or some blocks rather than increasing the intrathecal dose to avoid adverse respiratory and cardiac events. Position of the patient using isoveric drugs. Position of patient giving spinal does not matter. Sitting, lateral, or even prone position can be used. Plain levobupivacaine 0.5% is slightly on the hypovaric side, and if given in sitting position and patient kept seated for some time, can lead to high levels of blocks. Temperature of the drug has inverse relation with varicity. So warmed at 37 degrees, it can become slightly hypovaric, and cooled at 24 degrees, it can behave like hyperbaric drug. So even such minor differences in varicity can lead to completely opposite distribution pattern in sitting positions. When you are using a combination of hyperbaric and isoveric drugs, sitting position is mandatory initially for hyperbaric drug to settle down. The type of the spinal needle. When it is combined with epidural, and if you have a CSC kit, that is the easiest and safest option. Either Quincke or pencil point needle, either of them can be used. Embelloni et al. In a study of 300 patients using cutting or pencil point needles for incidence of paresthesia and neurological complication afterwards, they found paresthesia in 20 patients, 7 with cutting and 13 with pencil point needles. All paresthesias were transient with no neurological complications afterwards. More than 2,500 surgeries over 8 to 10 years, initially used for only high-risk patients with multiple comorbidities, now occupies nearly 50% of my SAV profile. Till date, very few partial failures, but no mishaps. I usually combine epidurals for major surgeries and use either a transverse abdominis plain block, rectus sheath block, erector spinae plain block in abdominal surgeries, and pectoralis or serratus anterior plain block in breast surgeries for post-op analgesia. Also used in pediatric cases and prone position spine surgeries with good effect. Complete pre-anesthetic evaluation of the patient is done, venous access, minimum mandatory monitoring as per patient's condition is attached. No sedative pre-medications are used. I use lateral decubitus position for spinal with 27 gauge quick needle. And depending on the patient's parameters, the site and type of surgery, the dose of local anesthetic agent and the site of injection is selected. I usually use 0.5% bupivacaine with either fentanyl, clonidine, or dexmedetomidine as additive. Dose and the site of injection for abdominal surgeries for average female 2 ml plus additive and for average male 2.5 ml plus additive. When combined with epidurals, with epidural backup, very low initial dose, even 5 to 7.5 milligrams initially is used in patients who are having multiple comorbidities. Usually T10 to L1 interspace for abdominal surgeries, and for thoracic and breast surgeries, 1 to 1.5 ml maximum of the drug and T5 to T7 interspace. Speed of injection is usually average as allowed by the bore of the 27 gauge needle, around 1 ml per 15 seconds. Patients are usually turned supine after the block, and for lateral position surgeries, patients are kept in the same position with operative side up. Sensory block tested by pinprick usually sets in 3 to 4 minutes, and touch sensation, which at times persists in some very highly anxious patients, can be relieved by a few milligrams of ketamine or fentanyl. Complete block usually sets in 8 to 10 minutes. There are no drastic hemodynamic fluctuations. A slight fall in blood pressure and pulse in the first 10 minutes can occur, but usually it is very gradual and minimal. No respiratory embarrassment can be seen even with high thoracic and cervical root involvements. Initial partial involvement of the lumbosacral roots may be seen when high doses at lower spaces are used, but usually recovers by the end of surgery. No additional supplements in most cases are required, barring few laparoscopic cases where the adequate levels are not achieved. Patients can be mobilized in 4 to 6 hours. A fact that anesthetic technique is not usual does not mean that it's wrong. A concept has developed that regional anesthetic should need no supplements, and that if it does, it should be considered a failed block. This reasoning needs rethinking. Patient safety takes precedence over the unnecessary risks to be taken for success of the procedure, and the technique is reserved for experienced clinicians with good learning curve. To sum up, very useful technique with many advantages and minimal risks with due precautions. It takes little time to onset and complete effect. There is no need to panic even if the block level is found to be higher than desired. It's mostly sensory due to the low doses of the drug use of the fine gauge needles for daycare procedures, and lap surgeries may little more sedation as it is under all regionals. Now I'm showing some videos. This is at the lower thoracic level, just to show how straightforward it is, as just like lumbar levels. Heavy draping is avoided to have a clear view of the, it is as straight as lumbar spaces, which is around T11-12 space. This is a morbid obese patient, 133 kg, for hysteroscopic removal of the polyp, having hypertension, diabetes, and the spinal was given in sitting position at T12L1 space to have some sacral involvement also. This is the same patient after 1 hour. You can see complete regression of the effects. This is the same patient after 3.5 hours, ready to go home. This is a very morbid old lady undergoing open cholecystectomy. She was having diabetes, hypertension, ISD. This is a patient of radical mastectomy done under combined spinal and epidural. Epidural is put and spinal also given. This is the levels being tested. You can see the levels being tested. Patient is very comfortable, even the levels are very high. This you can see here. She has no sensation C71 level, but the grip strength is good, indicating only sensory block. This is radical mastectomy going on in the same patient. This is a patient being interviewed during
तकलीफ
surgery,
में सुई की?
laparoscopic surgery.
नहीं,
अभी कोई
You
तकलीफ
can
हो
see
रही?
she is very
नहीं।
comfortable.
कुछ भी नहीं?
कुछ भी नहीं।
कंधे में वगैरह दर्द कुछ?
नहीं।
जीभ दिखाओ। ठीक।
This is a laparoscopic ruptured ectopic. You can see the patient moving her legs during the surgery. This is the same patient at the end of the surgery. The port closure is going on. You can see the complete regression of the effect in the lumbosacral roots. The same patient shifting herself from table to stretcher. This was a unique case of traumatic diaphragmatic hernia done under combined spinal epidural. Young male patient. You can see the whole of the left hypochondrial contents were in the left hemithorax. You can see the mesh repair of the diaphragm going on. See the same patient at the end of the surgery. Comfortable, ready to shift himself. The next day X-ray picture of the same patient. You can see the complete expansion of the lung, left lung. This is umbilical hernia. You can see the regression of effect at the lumbosacral roots, and also some innovative technique was used for post-op analgesia through the drains. These are the methods I usually use for monitoring ETCO2 in patients with segmental spinal. One is with the intracath 18 gauge, and the other ETCO2 port is attached to the mask. This is laparoscopic cholecystectomy in which the ETCO2 is monitored. This is an open feeding gastrostomy in a patient post-cricoid malignancy. There was complete obstruction at the level. This is open hydrated, liver hydrated. This is DU perforation. When the video is not playing properly. This was a large incisional hernia in a morbid old lady with multiple comorbidities. You can see the patient after finishing.
उधर का बस सीधा करो, जीभ दिखाओ.
This is a recent case of perforated appendix having pus pelvis. You can see during the surgery she is being interviewed.
Hi, hello तुझे.
She can move her legs during the surgery. This is ruptured appendix, perforated appendix, having a lot of pus. Thank you very much for patient listening.
Thank you, sir. Now the platform is open for the chairperson for the discussion. Over to chairpersons.
Legs during the surgery.
May I start? I'm Dr. Ramdas.
Perforated appendix.
I must thank
Hello.
Shalu and Dr. Naresh for this.
Hello, good morning, sir.
I must thank both of you for your wonderful talk. I have a question, regarding the segmental block. You said
Okay.
it is an accepted and approved technique. Then I wonder why it never became that popular.
Thank you,
What
sir.
is there any reason for
The
that?
platform is open for the chairperson.
It's just because of the fear of injuring the spinal cord. It did not, become popular. Still,
May I start? I'm Dr. Ramdas.
hello.
Yes. I must thank Shalu and Dr. Naresh. Because of fear of trauma, neurological injury, you mean? Wonderful talk. I have a question regarding the segmental block. You said it is an accepted and approved technique.
It's not thorough.
Why it never became that popular?
Just because of the fear of. It's just because of the fear of injuring the spinal cord. It did not, popular. Still, there are many references to it. Hello.
Yes. So I have one more doubt. trauma, neurological injury, you mean?
Yeah. The it is
Yeah, do we require preservative-free for isobaric use?
yeah, we generally use the preservative-free isobaric drugs. They
Okay.
levoanavine which comes is preservative-free.
Okay, thank you. That just want to know that. Okay,
Okay.
thank you for that. One more doubt. I have one more doubt.
Yeah.
Hello.
Yeah.
Hello.
Hello. Hi. Hi, Josh.
Naresh.
It is
Hello.
Require preservative-free
Participants, if you have opened the
we generally
browser,
use preservative-free
the virtual conference, please mute that one or close it.
levoanavine which comes
We
is
can hear the echo.
Okay, thank you.
Yeah, we are hearing the speech which is in the coming others. Please, all the participants in this Zoom, please close the other one or mute it. Otherwise, what we are hearing is after 30 seconds, I am hearing back what the speaker is speaking. That is because
Yeah,
nobody.
there's
Please close your
hello.
other thing when you are here.
Participants, if you have opened the browser, the virtual conference, please mute that one or close it.
Which comes
We can hear the echo.
Yeah, we are hearing the speech which is in the coming others. Please, all the participants in this Zoom, please close the other one or mute it. Otherwise, what we are hearing is after 30 seconds, I am hearing back what the speaker is speaking.
Yeah, there was some time lag.
Yeah, the time lag. That is what the speaker says from the other one.
Participants, if you have opened the browser, the virtual conference, please mute that one or close it.
Hello, Naresh. Naresh sir, can you hear me? Very nice presentation. And also practice a lot of segmental epidurals. You know it.
Yeah,
Problem which most of the surgeons have been telling me is that when you give segmental epidural, the legs keep on moving. So sometimes,
yeah.
so they get distracted, or sometimes they are not happy.
No.
But,
With
so sometimes that can be a little problem.
yeah, I can hear you.
Yeah. So that can be a problem sometimes when the legs start moving. There's a lot of segmental epidural the surgery.
Yeah.
So what do you do regarding
The
that?
difference between segmental epidurals and spinal is
Spinal.
yeah, in the spinal the block is very much dense, and there is some involvement of lumbosacral roots initially, which usually recovers by the end of surgery. So unless you tell the patient to move the legs, he will not move the legs during the surgery.
Sometimes they do move the legs, especially while doing radical mastectomies and all.
Yeah, no issues. Some issues they can occur during cautery. If the current is very high, the patient can segmental
and they start moving the legs, and the surgeon gets very
if the current is very high in the spinal, but that can be subdued with some sedation like Dexcate I use.
Yeah, that we do.
Yes, I had done quite a lot of radical mastectomies.
Under spinal.
Results were very good.
Only problem is that the legs start moving in the surgery.
With cautery, especially when using cautery.
High volume cautery.
They can occur during cautery. If the current is very high, patient can. I ask the surgeon to reduce the currents. If the current is very high, you can keep the patient sedated with drugs like Dexcate I use, dexmedetomidine
I
and
also use
ketamine.
Dexcate.
Yes. Otherwise, with little more drug, you can involve the lumbosacral roots as well.
Yeah.
With cautery. Yes.
But Naresh, very nice presentation.
Thank you, Joy. Nice to see you.
Yeah, nice.
I asked the surgeon to reduce the currents. You can keep the patient sedated with drugs like Dexcate I use.
One question to Madam Sarupa, Madam.
Yes.
Ma'am, for all patients of preeclampsia, do you advise 2D echo?
The severe
Sir.
pre,
Yeah.
the severe the normal usual ones without severe symptoms are done like any other pregnancy for cesarean. It is the severe ones with cardiac involvement which we do echocardiography. For example, the pulmonary edema ones, the ones with ischemic symptoms, and such severe ones.
So ECG is also advised, ma'am?
ECG is done routinely.
Yes.
Severe ones with cardiac involvement, which we do echocardiography. For example, the pulmonary edema ones, the ones with ischemic symptoms, and such.
I guess, Naresh sir, you have opened the browser also. There you can mute it, sir. Sir, any queries?
Other two person, Dr. Lenin Babu. Shilpa, please unmute Dr. Lenin Babu and Dr. Bhimeshwar. Lenin Babu and they are the chairpersons for this session.
Hello, sir. Good morning.
Yeah.
Sir, good morning, sir.
Lenin Babu,
It was very well presented, Dr. Narli. Yes, sir. Can you hear me, sir?
Yeah, we can hear you, Lenin. We can hear you.
Yes, sir. It was well presented, sir, Dr. Naresh, sir. And personally, I don't have any experience in this segmental spinal. So what will be my thing is like, what will be your advice, the one who wants to start the practice of giving segmental spinal? And second question is, what would be the probable explanation that why the sacral roots are getting not affected? Well presented, sir, Dr. Naresh, sir. And personally, I don't have any experience in and I'm really sorry that yeah, I'm at a hospital. My signal is not very good here. Not affected. I just want to. I'll just.
Hello.
Yeah, I just. Personally, I don't have any.
You can start with the cases where it is most warranted. I mean, cases with bad chest, or in case you have accidental dural puncture during thoracic epidurals, you can just push a 1.5 to 2 ml of the drugs to tide over the situations.
Okay, fine. Like generally, what is the traditional teaching is, if the spinal segment is blocked at one level, that is going to block the entire sensation below the level of blockade.
The chest, or in case you have.
But here, roots are not that much affected. So, what could be the probable explanation for that, sir? I just want to try this technique. Like generally, what is the traditional teaching is?
Yeah.
Segment is blocked at one level. It's going to block the entire sensation below the level of blockade.
No, there are many factors which are involved. I mean,
roots are not that much affected.
With the isobaric drugs, it depends.
Explanation for that, sir. Try this technique.
Sir, your browser, you have opened a browser and their virtual conference is logged in, right? Can you just close that one?
I'm not able to close actually.
Browser, in the browser, sir.
There are many factors which are involved. I mean, with the isobaric drugs, it depends. I'm not able to close the browser. I mean,
Sir, your browser, you have opened a browser and their virtual conference is logged in, right? Can you just close that one?
okay, I'll just see to it. Actually, where it is, I'm not getting it actually.
Browser, in the browser, sir.
There are many factors which are involved. I mean, with the isobaric drugs, it depends. How to close it? I'm not able to close the browser. I mean,
Sir, your browser.
Sir, if you are using the Zoom, sir, if
Yeah,
you are
yeah.
using the Zoom, you can close the.
Okay, just see to it.
You can close the browser, sir, altogether.
Please, I'm not.
Later on, you can log in.
Hello.
Yeah, it is now.
Am I audible
Only
now?
your, only your voice is audible now, sir. Yes, please go ahead.
Okay.
Yes, sir.
Yes,
sir.
There are many factors involved why the lower routes are not involved. It depends on the volume of drug you use, site of injection, and the baricity of the drugs. I mean,
Okay.
with hyperbaric drugs, it usually settles with gravity. But using isobaric drugs, it generally spreads 1 or 2 segments. I mean, depends on the volume of the drug you use. Like if you use 1 ml, it spreads 2 to 3 segments above and 2 to 3 segments below. Not more than that. If you use a larger volume, then it can spread to lower segments also.
Yes, sir, I got it, sir.
And with hyperbaric drugs, it depends on the mostly on the gravity rather than on the site and volume of injection. But with isobaric drugs, it is mostly dependent on the site of injection and the volume of drug you use. So the isobaric drugs are more effective.
Okay.
Hello.
Hope, sir, that is very inspiring talk, sir. We'll all start practicing your technique and then we'll do it, sir. Thank you very much, sir.
Thank you.
And I thank you, Dr. Venkatagiri, for giving this opportunity for us to be a part of this conference, sir. Thank you very much, sir.
Chairpersons, any other queries? Bhimeshwar, sir.
Yeah, thank you so much. I don't have any questions. Thank you so much. It was a wonderful presentation by both the presenters, and then thanks to the Kerala State ISA for giving me this opportunity to be a chairperson. Thank you very much.
Thank you. Thank you for the patient listening and giving me this opportunity.
Ramdas, sir. Unmute, sir. Unmute. Yes, sir.
I must thank the presenters for their excellent presentation. I have no more questions to ask.
Thank you all the chairpersons and the organizers for giving me the opportunity. Thank you.
Thank you to
Thank
the
you, ma'am.
organizers. Thank you.
Thank you all the speakers and for your wonderful session. Thank you all the chairperson for chairing the session.
Thank you, Chairperson Dr. Bhimeshwar, Dr. Ramdas sir, Dr. Joy and Lenin. And also thank you, Speaker Dr. Naresh Paliwal and Dr. Shaluai. It was a new experience for us about segmental spinal. It was our dream of our president to have it detailed discussion on that. But he's in other hall because he was telling since a long time we should have a CME on segmental spinal and hear that. And a new experience for us. Only thing is now we are not getting isobaric bupivacaine.
Isobaric drug is now available only in vials.
In vials.
The vials you can use.
Is it sterile and?
Yeah, it's sterile.
Okay.
What I do is I use it only for one patient. The remaining drug I use in blocks.
Okay.
20 ml vial, one vial for one patient.
Okay.
For sterility precautions and this thing.
When I asked with the neon, they told that now we have stopped marketing, sir. We don't have.
Yeah, they stopped marketing 4 ml and 10 ml ampoules.
Whatever is there, he told that.
But the vials you can use. I am using the vials only, 20 ml vials, 0.5% bupivacaine.
Okay. Right, sir. Thank you.
Remaining drugs I use for blocks.
Okay. Right. Thank you.
Okay,
it was nice talk and nice experience.
Thank you very much.
Okay, we shall call the action and we will go for inauguration in Hall A at 11:15, and all halls will directly relay that same thing. Thank you all. Thank you, faculties and chairpersons.